there were so many communication that it appears I have seen you many times. You are from Delhi, and she will give you a proper introduction de do. And I am very happy in the way that you have come all the way. Traveling these days so difficult, and so you have come alone, and we were very in anxiety that how we will reach here. So your that journey was comfortable, ne? Okay. So this is our devotion. This is our devotion for spreading knowledge. Knowledge, if you have got knowledge, it should be spread. And if you have got knowledge, then let others to lit their candle from it. So that is the doctor. They think that the doctors are coming, earning money, but what is behind that and how much is trained, and in juniors training, always want that juniors should be trained. And it all is for benefit of society. So, with these words, I welcome you, Dr. Bandana, and you start your talk. No, civilly start. No, lightning of talk.
A very good morning to everybody and respected seniors, Dr. Vandana Chadha, Madam. It's been a quite hectic schedule for us because of the PCP and DT Act. We had a lot of struggles. We could not get, till the last moment, we could not get the PCP and DT clearance, but with the help of all the members, with the help of Civil Surgeon Sir, with the help of District Magistrate Sir, and our Union Minister, we had to involve our Union Minister, Dr. Rajbhushan Chaudhary Nishad, and then with the help of everybody, we could get the PCP and DT clearance for this workshop. So I welcome you all. I hope that we all have a very good learning experience today. Dr. Vandana Chadha, Madam, is a very renowned fetal medicine specialist from New Delhi, and we should start as soon as possible so that we can extract maximum information. Most welcome, Madam. We'll have the lighting of the lamp.
I recognize Dr. Prachi Singh, that she has taken so much trouble, and how much time she has devoted in arranging ultrasound workshop. So I am very happy that she could come, and you will be also happy that from your society people are so devoted. President, Secretary, I am actually very happy because what I wanted from you have done exactly. So thank you, all of you.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
सिंदूर लाल चढ़ायो अच्छा गजमुख को, जोंदिल लाल विराजे सुत गौरी हर को। हाथ लिए गुड़ लड्डू साई सुरवर को, महिमा कहे न जाए लागत हूँ पद को। जय देव जय देव जय जय जी गणराज विद्या सुखदाता, धन्य तुम्हारो दर्शन मेरा मन रमता। जय देव जय देव कोई शरणागत आवे, संतति संपत्ति सब ही भरपूर पावे। ऐसे तुम महाराज मोको अति भावे, गोसावी नंदन निच दिन गुण गावे। जय देव जय देव, जय जय जी गणराज विद्या सुखदाता, धन्य तुम्हारा।
Let me have the honors to introduce Dr. Vandana Chadha ma'am. She is a certified medical geneticist, postdoctoral fellowship in maternal fetal medicine from University of Toronto. Present designation, she serves as director of Sattva Fetal Care. She has n number of publications and awards. Her major achievements have been 24 years of experience in core prenatal diagnosis, interventions and fetal genetics. She set up the fetal medicine unit in Moolchand in 2005 itself. She holds the membership of Genetic Medicine Committee FOGC AOGD, executive member of SOFM. I welcome Dr. Vandana Chadha ma'am to please capture your stage and captivate the crowd.
Good morning, everyone, and I heartily thank the organizers of Muzaffarpur Obs and Gynae Society, especially Dr. Prachi, who's been relentless in her efforts to keep this a very practical and patient-oriented and patient care-oriented session. So, one big applause for her before we start. ये इधर नहीं दिख रहा है। एक सेकंड। ये कैसे खुला हुआ है जब मैंने खोला हुआ है? अब ये ठीक है। ऑलरेडी है ना, एक सेकेंड। ठीक, आप करिए। So, the talk today, what we would be discussing today is the nuchal scan and the anomaly scan. And we thought we'll do nuchal and anomaly separately, but then I said the anomaly has actually shifted to the nuchal scan in my, at least, certain practices. So we would say we pick up 70-80% anomalies now in the first trimester. So I thought I will redesign my talk as to what all we have to see whenever we see the fetus, what we don't see and what has to spill over to the next trimester. We should have that checklist clear in our mind. So that will be the approach. And this is a slideshow, but I will like to share with the audience my slide sorter, before we start. So we know what our syllabus for the session is, since it's a long session. So the slide sorter here is that first we look at the general considerations. It's not visible. ये आ नहीं रहा उसमें. Slide sorter नहीं आ रहा. Why is that?
स्लाइड शो ये सॉर्टर में नहीं आएगा, स्लाइड शो ही में आएगा.
अच्छा, स्लाइड शो में ही आएगा.
हाँ,
ठीक.
स्लाइड शो.
Okay, so you can just, I'll read my slide sorter section so that it's not showing on the screen, but I'll just read it through. So the first part of the slide, the first section of the talk is general considerations, where we do the housewarming of the fetus, as I'd call it, when I first enter the fetal environment. That's my first section, along with the biometry. The second section is the first trimester and the unique markers and the unique things that we see in the first trimester. That's the second section. The third is when we look at the CNS, the central nervous system, the head and neck, and we look at the head and neck in totality, the first and the second trimester. So that's the third section. The fourth section is the face, and we look at the face in the first and compare it to the face in the second. Then we look at the spine. So I'm going head to toe, so it's not so hard. And spine we look in the first and second trimester. Our next section, as we call the Isiog 7, 8, 9, 10 planes, is the thorax, where we look at the lungs and the heart, and that is what we call the 7, 8, 9, 10 sections in thorax. Then we look at the abdominal wall, the KUB, which is the 11, 12, 13 and 14 as per the Isiog guideline. These things will get clearer to you as you move along with me. The Isiog has 20 planes, and so the 15, 16, 17 would be the next section where we look at the limbs, and in the end we'll just summarize as to what is to be definitely diagnosed in the first trimester, and what cannot be missed in the first trimester, and what has spilled over in the second trimester, and what needs to be seen in the second trimester. So we compare that, and Dr. Prachi was very keen that we touch upon preeclampsia screening. So in the end, as per the time and the expectations, we look at how to do a uterine artery Doppler and some of the PLGF and other markers that we use for preeclampsia. So that is the syllabus for the day. So let's see how much we can cover, and we move on to our first part, which is the housewarming, when we have just entered our uterus. So this is our uterus, and the first time that I sweep the uterus, the first thing that I need to see is the fetus alive or not alive? So the cardiac activity is my first impression that I take as I sweep coronal from top to bottom and side to side. I look at the number of fetuses that are present. I will try to do some hand movements so that even if there is no baby and no machine here, you know what I am trying to do. So from the near the pelvic end of the mother, I go up, I look at the liquor and the lie and the number of fetuses. Then I go from side to side and I look at the liquor, the lie of the fetus, the placental position, the number of fetuses, and I get a fair idea as I have done so, as I do more and more ultrasounds as you get older and more experienced. Even by looking at the fetus, by looking at the kind of bones you're looking at, the sulci gyri that you're looking at, or the kind of anatomical landmarks that you're seeing in that fetus, you can pretty well say this is about the gestational age of the fetus. Without measuring the fetus, your brain is already tuned to saying, so if somebody tells me I'm 20 weeks and there's a dating error and I put my probe and it's actually 18 weeks, I take a second to say this doesn't look like 20 weeks. It comes because I know at 20 weeks I have certain landmarks, I have a certain texture to the bone which I am looking at. I have a certain texture to the brain that I am looking at. I know there's a parieto-occipital sulcus which would have come at 20 weeks, which at 18 is not present, or the posterior fossa in the brain looks a certain way, and so many other things, or the texture of the lungs, or the texture of the liver, and everything. So it's like cooking, once you've cooked for years and years, you don't do measurements, you don't do recipes, you look at your dal and say, okay, ye to paki nahi hai, something like that. So your assessment of the gestational age, the placental appearance, the amniotic fluid volume, all of this can be a subjective assessment in your first sweep. So how important is this first sweep? It's like going to somebody's new house. और पहली बार हम आपके घर आए तो आप पहली और वो आखिरी बार आप करेंगे कि आइए ये हमारी बैठक है, ये हमारा किचन है, यहाँ हम खाना बनाएंगे, यहाँ हम सोएंगे, ये बच्चों का कमरा है, ये पीछे का आंगन है. But that is the last time you're going to be showing me that. Anytime in the future that I come to your house, you will not be showing me all of the details. So think about your first sweep of the ultrasound as your last sweep. That whatever you have not seen, look at fibroids. Very early on in my career, when I looked at a woman around 12 weeks where I did not see an ovarian tumor. And after that, you've conditioned yourself that no matter what, you have to look at the adnexa in your first sweep. So that if you have a malignancy in a young woman, you've done a favor to not miss it. Or you've done yourself a favor, the guilt of missing a malignancy in a young woman. So looking at the environment of the uterus in terms of the number of fibroids, or if you have an adnexal mass, all of that will be your first sweep. So this relation of the placenta to the internal cervical os is important. And I think it is a good practice point even whenever you document a low-lying placenta. Because again, that is easily, somebody else may see that baby later and may not realize it. It is a good practice to underline it, to highlight it as an important point so that somebody who's looking at it in the third trimester does not miss a low-lying placenta. Often we see reports where a placenta is low-lying but it's written hidden somewhere, and when you see a patient later in labor room or somewhere when you are not registering, there are so many papers, you may not look at that low-lying placenta. So make a point to tell the patient that your placenta is low, that it needs to be looked at in the third trimester, and that the report which you are... So I firmly believe that the scan you are doing is also the report you are making. If you have done a scan, you have seen a low-lying placenta, you have also written it, but you have not written it in the appropriate way. In the environment that you work in, when you understand the skills of your colleagues, when you understand the skills of people who might do the admission in labor, and you understand that at that point of time in the middle of the night, they may not register that it's a low-lying placenta. It is your sort of responsibility to ensure that it translates into practice when somebody else is receiving that patient. So I think it's a good practice to highlight or underline or make it bold or write it in the impression that it's a low-lying placenta. Similarly, if you see a previous to LSCS or previous cesarean or a low-lying placenta, where clearly I see that there are lacunar spaces, that I could not see the interface between the placenta and the bladder wall, where I feel there is a small index of suspicion of placenta accreta. Again, it is my, even if I'm not very sure, even if I don't think it's something which might happen, but I think it's a good idea to highlight it to the clinician, to give a call to the person who's going to be involved in the labor plan, that this is what I feel, this is something you need to look at, this is something you need to keep in mind. A call is also important in an accreta patient. So those are the points I think, and these are various placentas that you can look at when you're doing your housewarming. So I don't know if you can make out. So these are not normal looking. There's a thick looking placenta here. This is something where you feel there could be a abnormal looking edge of the placenta, or you have a stippling here in the placenta. So the placental texture, the placental location, and the placental all of that comes in the housewarming. So the umbilical cord is something which is very relevant to our care in the fetus. The umbilical cord has 3 vessels. There is a placental attachment to the umbilical cord, and then there is a fetal attachment. So I don't think it's a big deal if you have missed a marginal insertion or somewhat a cord which is little away from the center. But I think it's a big deal if you've missed a velamentous insertion with a vasa previa. So again, it's a good practice to see that the placenta is not low-lying and the cord is inserting it. It doesn't require much skill. So if you look at the insertion site there, and you clearly, my arrow seen there. So if you clearly see that this cord is inserting in the middle of the placenta here, and there is no question of vasa previa, it's a good idea to do that, even if vasa previa is rare. And at the fetal end, you can see the cord inserting in the fetal site, and the bladder is here, and we all know that the bifurcation of the cord here signifies that there are two umbilical arteries and one vein, so this is not a 3-vessel cord. So the documentation of a 3-vessel cord and eliminating the possibility of a 2-vessel cord is there. And I think a vasa previa would be comfortably excluded if you looked at this. So those are the important things. The liquor, we'll talk about it. And these are the sweeps which are happening here, so the audience can look at those videos while I talk about the liquor, because I'll elaborate a bit more on those sweeps. These are just housewarming sweeps, but you see how much information I'll give you in those 30-second sweeps. What about the liquor? How do you report the liquor in your reports here? And we can interact a bit. Whoever scans can volunteer. Like if you do a... Okay. So you would like to report it as a deep vertical pocket, right? So the AFI can be reported as 4 quadrants and you measure them, or you can report it as a single vertical pocket, whichever is the largest vertical pocket. It is said that in literature that if you are reporting oligoamnios, which is the common scenario, which is what we are always looking for, especially for pregnancies which are nearing dates or post-dated. So if you have a oligoamnios, the better way to report is the single vertical pocket. If you have polyhydramnios, where you have more liquor, which is a rarer scenario, where you will have liquor exceeding 30, 35, 40 and so on, the better way to report would be AFI, maybe. But yeah, the single vertical pocket is a good idea, especially because if you see a pocket more than 2 centimeters, especially towards 39-40 weeks, say 3, you will not do iatrogenic premature deliveries for fetuses which have good single vertical pocket, because AFI you will tend to over-report the oligoamnios. That's the concept. Okay. So with the single vertical pocket, you will you will not over-report the oligoamnios, and you will probably take that baby more towards term rather than delivering it at 38, 39. If you use AFI, your AFIs may come lower more likely. So let's look at these videos. And again, who are the ones who are little ahead in their scanning skills? I would not know. So those who do ultrasound regularly. Okay. So we can kind of ask them a little bit questions so we can have interaction. So this is a video that I put here. So it's a very short clip here. So anybody can volunteer and tell me what you can see, what all the landmarks that you see in this video. So we start the video with the sagittal spine, right? Yeah, you can see. So this is the sagittal spine. Okay, so we are seeing the sagittal spine here. Everybody can see that? Yeah, so that's the sagittal spine. What is important for me is to see the skin cover. So if I don't see the skin cover, I will miss the lower sacral open defects. So I am looking at the sagittal. So to see the skin cover, what is the essential thing that I need here? To see the skin cover? Like a baby should be away from the wall, and you should have amniotic fluid. Both of those things are important. From that sagittal, so this is, as we go along, we will also revise the ischioc plane. So this is the first ischioc sweep. So the first plane is this sagittal, the sag spine plane. The sag spine is the number one thing which you need to learn, because that is like it is like the, क्या कहते हैं वो गाड़ी का? It's like the steering of the car. So if you know how to take your sagittal spine, from that you see how quickly from the sagittal spine I've come to coronal spine. From coronal spine, I've understood where the head is, and I've moved my probe at 90 degrees and taken all my axial planes of the brain and easily turned my wrist a little bit and taken all of the planes of the face. And again turned my wrist and taken nasal. As you go along the video, you will see that. So, cavum, thalami, you can see the posterior horn, anterior horn. Are those structures visible? Cerebellum, cisterna magna. I'll speak along as I'm just focusing on one video, which is 30 seconds. Nose, lips, chin, the nostrils, the tip of the nose, the two orbits. Okay, so I have not removed my probe even once in this whole sweep. So this sweep and the nasal bone. So I start with the sagittal spine, move from side to side, look at both the kidneys. I'm also looking at the diaphragm. Move a little bit anteriorly in the abdomen. I can see the diaphragm and the stomach below the diaphragm. And then I change my probe to get an axial section, and then I move up to the head. Get the cavum, thalami, the BPD plane, the transventricular plane, the anterior horns here. Tilt a little bit and look at the cerebellum. And then move to the nose, lips, chin, the orbits, and again sweep 90 degrees to get the profile view. So I think I have given you I have excluded open spina bifida. I have excluded diaphragmatic hernia. By looking at stomach bubble below the diaphragm, I have excluded diaphragmatic hernia. I have looked at the lungs somewhat and told you that there is no CCAM or the positioning of the heart looks fine somewhat in the as expected, and the bowel looks normal. There's no ascites, there's no bowel dilatation, there's no echogenic bowel, and in the brain I have said there is a good CSP, so there's no ACC. The two ventricles look normal, so there's no ventriculomegaly, and the cerebellum looks normal, so there's no hypoplastic cerebellum or there's no posterior fossa cyst, and the orbits look normal, so there's no microphthalmia. The nose, lips, at least the cleft lip is kind of excluded, the cleft lip, significant cleft lip palate. In the coronal sections, I think I saw the kidneys, but you can work on that. And I saw the stomach bubble, the gallbladder, the aorta. So if I know the orientation of the fetus, I have also done my situs. So the stomach was on the left side, the portal vein was in the center, the gallbladder is, so the right side is up, the left side is lower. So we have also done our situs. So the right, it's a cephalic presentation, if you can guess that, because based on that I can see this way the orientation of the stomach, gallbladder, spine, etc. I can say that this looks like a cephalic presentation. Just if the situs is normal, it would be a cephalic presentation. So the bladder is, the urinary bladder is also seen there. The texture of the placenta looks normal. The placenta is posteriorly located, so I would like to see the edge of the placenta there. But even in this one sweep, I think the amniotic fluid is looking normal to me. It's not looking oily or poly. If you're going by single vertical pocket, in your subjective sweep also you can see it looks 4, 5 centimeter, looks normal, average type of SVP. So the profile view was neatly seen there. I could see the nasal bone, and I can see even one IVC going up, and the coronal spine, you see there is no hemivertebra. Hemivertebra is something you can see in the coronal. So I'm playing this video again and again and telling you the anomalies which are being missed. So please focus on the anatomical landmarks that you've excluded even in this one sweep. So that first sweep is the sagittal spine sweep. This is another sweep where with the same baby, we have started from the head and axially go down, and then you see the cord insertion there. And from there you can move on to the limbs and look at the limbs. So this is a very important sweep. There's the SAT spine sweep where you sweep from side to side and get both the kidneys also. I think all this is clear to everybody, the first section. The first section is about the sweep of the uterus. Then we come to the biometry. Okay. So what is the biometric parameter that you would like to do in the first trimester? Which is the most important biometric? It's the crown rump length. It's the crown rump length, right. So the crown rump length, so I think those who scan can easily tell me the criteria which you use for the anatomical criteria that are essential to look at the CRL. Like what would you checklist? Let's keep the theme of this session, the checklist for good scanning. So what is the checklist for a good CRL? Yeah, it's neutral position and the sagittal section. So what are the landmarks that you will see in a good mid-sagittal plane? They are the same as the landmarks that you see for the nuchal translucency. So the same sections, the same section that you do for the nuchal translucency, you will do for the CRL. And so again, this, I was looking at sweeps, now we are looking at the one single image. This one single image, what all is it excluding for us? If you have the dates in hand and you've measured the CRL, you know there's no dating error. And this is the only plane where you can see the you can see the cranium here, so you can see somewhat that the cranium looks fine. I don't think there's any acrania because I can see the good skull contour here. Then I can see this nice bright shiny nasal bone which looks brighter than the skin on top of it. So in the first trimester, we just say that the nasal bone looks brighter than the skin on top of it. If you imagine the equal to sign that we use in mathematics, the lower part of the equal to, and this is the upper part of the equal to. The lower equal to is the nasal bone, the upper equal to is the skin. All you need to do is compare the echogenicity of the lower to the upper. If the echogenicity of the lower is brighter or whiter or more echogenic than the upper line, the nasal bone is present. If the lower line is less bright, less white, less echogenic than the skin line on top, then the nasal bone is absent. This is how we report the nasal bone in the first trimester. Okay. The other thing that you can see, what are the bones that you see here? You see the nasal bone, you see the maxillary bone and the vomer bone. The vomer is one single bone there in the center. So what you see here is not one bone, these are two bones, the maxillary and the vomer bone. And then you see the mandible here. So these are the bones that you see. These are the landmark bones, and you've seen the contour of the frontal bone. Okay, that's the frontal bone. You see the contour of the frontal bone. Then this is the structure which is called the thalami. That's the brain stem. That's the fourth ventricle. We have more slides which will describe that. But if you are tuned to looking at all of the landmarks here, the thalami, the brain stem, the fourth ventricle, the cisterna magna, the nuchal translucency, you've looked at the little fluid here between the thorax and the chin of the baby. You know the baby's head is neither too extended nor too flexed, and the calipers are well placed. So I think the image magnification is fairly good. So in the same image, if you magnify, so you see this much of the image, this is where you will be measuring your nuchal translucency. So it is one image. It's about the time you take to take this image. This is all you need to do in the first trimester, that you've looked, and because you've looked at acrania here, even the abdominal contour, if you look carefully, you might miss an omphalocele if you just look at this view. You'll have to take the axial sections also, but you can see the abdominal contour also. So the crown rump length is a biometric parameter to go for in the first trimester. And all pregnant women should be offered a CRL at early pregnancy, and that is a grade A recommendation for good practice. There is no excuse for not doing a CRL in the first trimester, because all your decisions, important decisions in delivery later on in the pregnancy, will hinge on that one dating that you did in the early trimester. If you've not dated a pregnancy in early trimester, what do you do? If you get patients, which you must be getting patients all the time who come to you at 16 weeks, or 17 weeks or 18 weeks for the first time, how do you approach that patient? Any clinician can take it who doesn't do ultrasound. So the ISIOR guidelines say that if you have a patient who comes to you for the first time in the second trimester, you use your head circumference, or you use a combination of the head circumference with the femur length and then date the pregnancy. And in a subsequent follow-up scan, which can be done 4 weeks later, you can confirm that what you projected as the gestation is being properly marked in your follow-up scan. So if you label somebody as 20 weeks and call them back after 4-5 weeks at 25 weeks, then the measurements of the baby correspond to the 25 weeks. So a dating which has been done using the head circumference, and then a subsequent follow-up which has confirmed that the projected dates were correct. This would be the way forward. So I think if you've done a CRL, you don't have to do all of that. So the crown rump length, the nuchal translucency, what is the advantage of doing a biparietal diameter in the first trimester, a head circumference or a AC or a femur length in the first trimester? Should you do it? Should you not do it? This is again for somebody who scans the whole day. Even if I look at a biparietal diameter, I would know that it looks smaller. But if you want to pick up an open spina bifida, say, in the first trimester, an open spina bifida will have a smaller BPD. So if you find that a CRL is 12 weeks, but the BPD is measuring 11 weeks, you should get suspicious of a problem. So maybe in initial part, if you have the time or if you have the inclination to form certain concepts, you can do a BPD. Similarly, if you have a femur length which is measuring smaller, you may be looking at a potential skeletal dysplasia. So if you do your measurements, it gives you more sort of overview of what potentially could be happening later in the pregnancy. Otherwise, a CRL or just a BPD should suffice in terms of the measurements in the first trimester. In the second trimester, of course, all of you do the BPD, HC, AC, FL, all of that is done routinely. That is reported by the radiologist. Right. So the biparietal diameter. So again, I would, since these are very easy things to anybody who does the biometry routinely, would have to checklist so when I take a plane, I would like somebody to point out at least 3 anatomical landmarks. Okay, so when I say a BPD plane, you should be able to go back today and say, when I say BPD, I don't mean BPD, I mean 3 checkpoints in the BPD. Okay, so let's move on to our first plane, which is the BPD plane. And we don't look at this side of the screen, focus on the image. All of you just focus on the image, don't look at the written material. So this structure is the cranium. Okay, just do not look at the written word, otherwise you won't remember later. What is this structure here? That's the fox. Is the fox interrupted or uninterrupted? Is it a continuous line or the line breaks? It breaks. Does it break in the middle, or it breaks in more anteriorly, or it breaks more posteriorly? This is the anterior, this is aage, this is posterior piche. It's more anterior. So it's the anterior 1/3 and the posterior 2/3 for sake of remembering. Do you feel that the two sides of the brain, which the line is halving, are equal to each other in this section? Yes. What else do you see here? Do you see any structure of the posterior fossa here? Do you see the cerebellum or the cisterna magna or the nuchal cisterna magna or the cerebellum or the vermis? You don't see it. All you see is the fox here. This is one of the sulci, but you don't see anything else. This is one of the sutures. Okay? This is a suture here, frontoparietal suture, parieto, occipital and all those. So this is, so I think 3 landmarks are easy now. One is the CSP, which is the break in the forks. One is the forks, cranium, 2 halves of the symmetry of the 2 halves. So the landmarks you need to remember for the BPD, and these are the same landmarks you will also remember for the measurement of the second measurement, which is the head circumference. So the BPD is measured here from outer to it used to be outer to inner, but now some authors recommend outer to outer and so on. But our machines have still got the Hadlock, which is outer to inner. So we do outer to inner. And the head circumference, even when we were students, was outer to outer. Even now it's outer to outer. So you place the calipers on the outer surface of the skull. So we, this is how we measure the head circumference. Now we come back to our AC here, and what are the landmarks that you see in the abdominal circumference? Yeah, spine is to the left in this image, but it could be here, here or here, anyway. So let's again let's look at the spine only. How do you see the spine here? It's seen as 3 points which are like a triangle kind of thing. So when you see the spine here, you see that it's the you don't see it's a nice neat axial section of that vertebra. So you can see the body and the 2 transverse processes here. And it doesn't look as if there is any obliquity to my section here of the spine. Similarly, when you see the ribs here, okay, so next, anybody else can volunteer? What other thing can you see in the section? You can see the stomach bubble, what you see, what you can't see, or what you see different from what you see. Everything is important. So if you see the stomach bubble, which is what you're used to seeing, that's good. If you see no stomach bubble, you need to document it. If you see a stomach bubble, but you see another bubble, you need to document it. Or you see some other structure here, or you see a stomach which seems larger than what you're used to seeing, you need to document that also. So an absent stomach bubble, so you see a stomach bubble which looks normal, abnormal, same as routine, looks normal. Okay, so that's my second landmark. Then, which moves away from the stomach bubble, okay. So it's moving rightward, which is away. If it's not moving towards, it's moving away from the stomach bubble. And if you look carefully, this is a aorta, which is right in front of the spine. This is the IVC, which is a little rightward of the spine. So you see a nice normal axial section of the spine. You see ribs which form neat circles and don't look like you are obliquely cutting 2-3 ribs. It's just one rib. You look at the stomach bubble, which looks normal in size. This is the portal vein moving away, and the abdominal wall, etc. So aorta, IVC and all, if you can, but you don't have, if you can remember 3 things: axial spine, circular ribs, stomach bubble, maybe the portal vein. So this is enough. 3 landmarks is enough. Rest you can grow as you go. So that's the AC. So the abdominal circumference is also measured in the transverse section of the fetal abdomen. Umbilical vein at the level of the portal vein. Stomach should be visible. Kidneys should not be visible in that section. And the calipers are placed outer to outer. You can even measure the transverse and the anterior-posterior diameters, and machines can calculate the AC for you. In our new machines now, the Hera, the new machines that we have assist, where you can open the assist and the machine measures the AC for you. So manually we don't measure it anymore, we can get and it corroborates quite well with the manual measurement. Okay, so the third thing is the femur length. I think that's easy. Only thing is you should take it, so the ultrasound beam should come at 90 degrees. So your length of the femur should be there, and everybody understands the femoral head. So this is the femoral head, you can't measure this, your measurement starts here. And that's the lower femoral line, so it should be a straight measurement. So your ultrasound beam is coming at right angle to this femur. Okay. So I think for the biometry, once we have done the BPD, HC, ACFL, you have formula, they will calculate. How are you in the practice of reporting centiles now here, or do you still report as weeks? All of you are reporting centiles. So what is a centile? It is the deviation from the median. So we have charts now, and it's a good practice to report in centiles. Also with the formula that you've used, so machine will automatically give you the formula so that you don't have to do. And fetal biometry charts should ideally be population based charts, so that's also a good practice. And if broadly you understand the Delphi consensus and you follow that in your practice as to how to approach IUGR, that will also be a good practice when you get a good day. Taking biometry alone is not sufficient. Anybody who takes a probe and reports BPD, HC, ACFL should have a good concept of how to date a pregnancy. When you are so when a scan comes to me, the first thing in our unit which we do is look at the CRL image. If I have a good CRL image and it's measured well, we date from there. We don't use the report, because so many times it's not, EDD is not given properly. So take a good CRL image, take the EDD from that, then put that EDD in your machine, take your biometry, and then use your Delphi consensus to decide whether you can label it as IUGR or not label it as IUGR. It has to be done in this way. You cannot have no dates, no EDD, just do your measurements and then report ki baby chota lag raha hai. It's absurd. So to complete the circle, this has to be, and it takes time, but it's a matter of habit. Now, like once you get used to it, you can't do it any other way. Okay. So this completes our first section. And any questions for the first section, then we'll move on to the NT, which will be our second section. We can take a 1 minute break for questions. Dr. Prachi, you can initiate the question answers. Or I can initiate the questions for the audience. So my question... Yeah, it's ideal. So if the ideal thing is, so it depends on the resources you have, the kind of patient population you have. So everybody can't wear the same set of clothes, and one glove will not fit all the surgeons. So when your patient has capacity to pay, when you have a good ultrasound machine, and when you book a patient in the first trimester, which is the norm all over the world, most of the world, developed world, the patient ideally comes to you when she misses her period. She is 6 weeks, 7 weeks, 8 weeks overdue. On her first visit, you know the urine pregnancy test is positive. You do an ultrasound, you date the pregnancy, you do the CRL, you do a transvaginal ultrasound ideally so that you can look at the adnexa, you can rule out ectopic pregnancy. And that is the ideal thing to do. And once you have dated the early pregnancy at 8 weeks by that CRL, that EDD or that date will stay for the rest of the pregnancy. You will not change it for anything. So if you have a very early onset IUGR, which can happen in a triploidy, a trisomy 18, or sometimes a trisomy 13, say at 12 and a half weeks, if a patient comes to you and the baby is measuring 10 and a half weeks or 11 weeks, it's a very significant drop in the centile for that gestation. So then you will be looking at a potential aneuploidy or something is happening there in the pregnancy. So you will pick up things as you move along. So that's the ideal thing to do. If you have a transvaginal probe, I think there's nothing like that to rule out, date the pregnancy. Okay. So my question again is, if your dating etc. is perfect and the fetus is coming to you at 38 weeks of gestation, and at 38 weeks of let's say 36 weeks of gestation, and at 36 weeks of gestation, all your Doppler values are normal, all the Likert is normal, the biophysical profile is normal, and the baby is measuring around the 7th centile. What would you call it, IUGR, or would you not call it IUGR? As clinicians can answer it. So her point is well taken. If you have a big drop in the center, so one thing is, if this baby has been at the 7th, 10th, 15th centile, 20th centile from the beginning, since we started, it was always towards the smaller centile. Then the 7th, 8th centile won't matter. This is just SGS, this is just familial. You will take this baby to term and handle it like any other normal baby. So it will be 2.6, you do it all the time, 2.6, 2.7 kilos, which there's nothing. But if this baby was at the 75th centile initially, and there is a drop in the centile, more than 50 quarters towards the end of the pregnancy, then that's a significant drop. But overall, if there is no significant drop, that significant drop would be rare. Mostly a 7th centile baby where everything else is normal would be not labeled as IUGR. So an absolute less than 3rd centile would be IUGR, but the 7th centile, if there is no drop, you have to have Doppler parameters. So that is what you have to look at your Delphi consensus, so that you don't overlabel growth restriction. So we move on to practical or second section? Second? Then we can. So coming, for people who have just come, welcome all. And the first section that we did was on the housewarming of the fetal environment and the general measurements of the fetus, and how do we date the fetus, and how do we call the fetus small or big, and so on. And the second section that we are doing now is on the nuchal translucency and the very peculiar things that are typical of the first trimester, and which are the anomalies that you can see in the first trimester and you cannot afford to miss in the first trimester. So the nuchal translucency is a clear space at the posterior fetal neck between the spine and the skin edge, and it's seen in the mid-sagittal plane. And we've already discussed that plane at length. It's the same plane in which you do the crown rump length at the 12 weeks. It's the same plane where you can see the NT, it's the same plane where you look at the nasal bone, it's the same plane where you look at the intracranial lucency. So it's just one image that you need to recognize. We have centiles for the nuchal translucency, but you have to remember absolute values. Then 3 mm is 95th centile, and 3.5 would be 99th centile. And anything above 2.5 is something we look at carefully. But we've had downs where the NT was 2.4 or 2.2. So again, it's like cooking. The formula is for beginners. Once you get used to looking at, so you can have the thickness which extends a little bit here and there. So it's not, it's a plane, it's not a line. So the subjective impression that you get as an observer is also important. And of course, the clarity with which you communicate to your colleagues is because of that one line, so we need to know how to measure it. So the nuchal translucency, this is a chart where you can see as you go along the crown rump length, the NT actually increases. So the centile curves would change as you go in the gestation. So if you have a higher size baby, the NT would actually be a little higher, so you need to keep that in mind. Smaller baby would have a smaller NT, and the medial NT keeps on moving up as you move up the crown rump length. What are the causes for large NT? It's not just aneuploidy where you have a little bit of genetics here. So genetics is like, I always say, like the Google map. And if you look at the 46 chromosomes, which are the 46 books in your library, any one book more or one book less is the trisomy or the monosomy. So you have a trisomy 21 because you have one extra 21 chromosome book there. So that's the concept of a trisomy, aneuploidy. Aneuploidy is trisomy or monosomy, where you have the entire book which is extra in your library. But you could have a few pages which have been torn off one book. Each book has millions of pages, millions. Okay, so if you tear off a few pages, a chapter maybe from a book or a couple of chapters from a book, that will be akin, or that will have the same analogy as having a large deletion or a duplication. So if you have extra pages, it will be a duplication. If you have many chapters missing, it could be a large deletion. What if you remove a single letter and shift all of the letters in the book? Okay, so in one of the chapters, now all the books, but just say one of the chapters, each book has multiple formula or multiple recipes to cook something. So let's say one particular recipe, you have removed a couple of letters or one letter, and the entire पूरी शब्दावली ही आपने शिफ्ट कर दी है, तो हर अक्षर का मतलब बदल दिया है, and the meaning of the story has changed so significantly that it's not able to cook or manufacture that particular recipe anymore, and that is what is the Mendelian disorder. Just one letter missing. Or you could have none of this and just a structural problem which is not related to genetics but which happened in one of the structures of the baby. So if you understand all of these concepts, you understand that the large NT may be associated with aneuploidy, may be associated with trisomy or a monosomy X, or it could be associated with deletion or a duplication, which are large deletion duplications like 22q microdeletion. Okay, or it could be a single gene disorder where there's just one letter missing, like the Noonan syndrome. It's a Mendelian disorder, it's autosomal dominant. It could happen de novo also. It could come from one of the parents where there is so much variable expressivity that in your pedigree or in your history it may not have expressed. So that single gene disorder could also cause a large nuchal in a fetus. Or you could have none of these and just a heart defect or a skeletal dysplasia or anything which has caused the fetus to have a large nuchal, a structural malformation. So the causes of large nuchal, so when you approach, could be any of that. If the large nuchal persists, that's more significant. If it goes away, that's less significant. And again, coming to the images, so we have already done all this. So I think the audience knows now very well. These are important images, so you revise again. And which is the correct image in this? So in these, which is the correct image to measure the NT? Yeah, so that's easy here. Anybody has doubt which is the correct? Everybody understands, okay? The correct zoom is where you see the head, where you see the upper thorax and not the entire baby. That's the correct zoom. Okay? So when you see this NT here, do you think it's normal, abnormal? That's a large NT because the NT is measuring 3.2 millimeters or 0.32 centimeters, and we've understood that 3 mm is 95th centile and it's between the 95th and the 99th centiles. So it's a large NT, but you can see the nasal bone here. Okay, sometimes you can have, even in the embryo, at 8 weeks, 9 weeks, you can see the embryo which is swollen. Not the conventional NT, but you can. So let me show you this case where there was a swollen embryo. So she's our resident only, so we have followed her from beginning. She had first pregnancy, missed abortion. Second pregnancy, she had this swollen, because I was seeing her from beginning, I saw at 8-9 weeks also. This is the kind of fetus you can see. Everybody can see the swelling. I'm not measuring NT, I'm just looking at the 8-9 week fetus. This fetus, we did the there was no microarray available in that era. This is before 2012. So we did the amniocentesis for the NT had resolved. So by the time she came for NT was normal. There was no large NT. It was just the embryonic edema before 10 weeks. NT became normal. Amnio done was normal. However, at 16 weeks, amnio done came back as karyotype normal, microarray not available at that time, in that year. And then at the 20 weeks, if anybody can point out anything which you feel is, yeah, very good. So this is a chin which looks abnormal, and there was some segmentation defect of the spine, and the CSP was thin and so on. So the findings were very subtle, but they were there, dysmorphic. And since she was our own girl, she was convinced by these findings and she terminated the pregnancy. And the baby had that posterior looking chin here, and you can see the posterior cleft in the autopsy. So there was a cleft here, and also the baby had the imperforate anus, which was not picked up at that 18 and 19 weeks. So this fetus was not tested and she didn't do anything. She didn't do her karyotype, as doctors never do their own checkups properly. Then in the next pregnancy, again the baby had tricuspid atresia. That is when we had, this is the third pregnancy when she had tricuspid atresia. That is when we did her microarray for the fetus, and the fetus was found to have the Cry-do Shat or cat cry 5p deletion. So 5 and the duplication in the 11th chromosome. So that's when we did her chromosomes and her husband's chromosomes, and she had a balanced translocation 511. Then she went to UK and did her pre-implantation genetic PGSR, and now she has a healthy girl. So this, how it played, because it started before I had microarray in hand. Then it was, the karyotype people didn't understand that there's something wrong. They reported as normal. Then when the microarray picked up the problem, then we did the parental karyotype, and then the parental karyotype gave us the hint that this is the reason why these successive pregnancies are being hampered. Okay, so this is again the nasal bone which we have discussed. I have already defined the criteria. So again the audience knows how to, is this normal nasal bone or abnormal? Absent nasal bone. So everybody, and also who else is there? This is also a large this is a Down syndrome. There's a large nuchal and an absent nasal bone. Okay. So the nasal bone is hypoplastic in 65% of cases of Down syndrome, and not all cases. So that is what you need to remember. We have had a spurt of absent nasal bone referrals now to us last 2-3 years. What we have realized is that of all of the 100 patients who come to you as a first trimester absent nasal bone, I would say about 80% would end up getting a nasal bone within the next 2-3 weeks. So if the mother is obese or it's too early in the pregnancy, we kind of reassure them and tell them that go away and maybe 16 weeks it will come back. And you have to tell them that absent nasal bone doesn't mean ki bacche ki naak nahi hai and all that, because they think there's no nose. So that it just means the nasal bone is there. It's not ossified enough to see, because parents get very disturbed when they hear that term absent nasal bone. And now there is a lot of literature which says that 5 to 7% of early fetuses may not show the nasal bone, and it comes easily. Only 1% eventually would actually have a true absence. So calling them back at 16 weeks and then reviewing again and deciding on NIPT or amnio would be a good choice to make. Okay, and trisomy 13, trisomy 18, trisomy 21, all of those could have absent nasal bone. Megacystis is another criteria for aneuploidy. It's more than 7 mm of the bladder, and it's present in 1 in 1500 pregnancies, and also could be associated with chromosomal abnormality, genetic syndromes, or structural malformations. So I've already explained to you that whenever you see a difference or a malformation or any different finding in a fetus, always approach it from the perspective of whether there could be aneuploidy, whether there could be a deletion duplication, whether there could be a single gene disorder, or whether there could be an associated structural defect with it. So when I give you a megacystis, to the esteemed audience here, what is the kind of anomaly that you would sort of get fearful about? If I tell you कि 12-13 हफ्ता का बच्चा है और उसका urinary bladder बहुत बड़ा लग रहा है, normal 5 से कम होना चाहिए, the longitudinal diameter. Now here the longitudinal diameter is approaching 10 mm. What is the kind of structural defect that you might anticipate in the pregnancy? Of the urinary tract, yeah. So the anomalies of the urinary tract, especially those related to obstruction of the lower urinary tract, is what you would be most fearful about. What would be the kind of aneuploidy that you would fear? In a megacystis, the literature says trisomy 18. That's the thing, but 21 and the others could also happen. But it's the 18 which is most likely, and the genetic syndromes, etc. are less, but you could have various genetic syndromes which could be associated with luto. What about first trimester growth restriction? I've already explained to you, if you date the pregnancy at 8 weeks, you can pick up the first trimester growth restriction. It's also a marker for aneuploidy, and triploidy is very, very clear in the first trimester. If you have dated, the baby drops immediately the CRL. So you can pick up triploidy in the first trimester. This is a case where you can see the very large head. This is a very old case. And the small body, which was the triploidy. Okay. And what about the Dopplers that you do report here in the first trimester? What Dopplers are reported? The ductus and the tricuspid valve. Do you report that also? Okay. So how do you do a ductus venosus? I'm not going into the details, but I want to understand how you interpret a ductus. If you see an abnormal ductus, what are the things you can associate that with? And again, our approach is same: aneuploidy, deletion duplication, Mendelian disorder, structural malformation. So when I say absent ductus venosus, what are the things you would think of? Aneuploidy, trisomy 21, even some of the others, like Turner's also. You can think of Noonan syndrome, 22q11 microdeletion, same things which are associated with the large nuchal, somewhat similar approach. And in the structural defects, the heart defects. So I think the ductus venosus is more important to screen for cardiac defects than aneuploidy. So if you have a normal looking NT and a normal looking nasal bone, but the DV is abnormal, always remember that the fetal heart has to be looked at carefully. Same goes for tricuspid valve. If you have a normal looking NT but there is a good tricuspid regurgitation, then you have to be looking at the fetal heart in detail. The tricuspid regurgitation we pick up a lot in the first trimester, almost in 5% fetuses, and it's not such a big deal. But just make sure that your anatomical checkup of the heart is good. So we are coming to the end of our first, the second section, which is the nuchal translucency. The surrogate markers for cardiac defects, the TR and the DV have to be looked at. And of course, you round it up with the first trimester uterine artery Doppler, which is screening for preeclampsia, which if we have the time later, we'll go into more detail as to how to do a uterine towards the end. So that is, I think, for the NT scan, if you have to revise, you do your NT, nasal bone, ductus venosus, tricuspid valve, the good CRL. One single image of the NT should be there in the report. And if possible, the structural malformations that you see, we will be doing system-wise. So, but this is a broad overview of what you need to see other than the structural malformations in the first trimester. Okay, so we'll...
Extremely very good and basic information. Now we will start the practical workshop, and the transmission will be here. So we'll be proceeding upwards, and after a few cases, then again we'll do the second trimester scan theory, and then again later on practical. So that is how we are going to do it. questions from here can be taken up. Dr. Smita, you can coordinate from questions from here. Thank you.